I'm very happy to introduce Chris Montenegro today. And Chris is working, he's based at the Wellcome Centre for Cultures and Environments of Health, another wonderful centre that deals with health and illness. And in particular, Chris's interest, he's a quantitative health researcher, and his interest is in activism and place and space. And Chris is going to be talking to us today about his work, which is the culmination of a 3-year project on the deinstitutionalization of psychiatry in Chile, in Santiago. And then it's going to tailor 2 talks today, isn't it, Chris?
Yeah.
Because he's going to talk to us about that project, which he's currently writing up. But then he's going to talk about his ongoing work into the future at the Wellcome Centre, which is part of the Healthy City project. And that's to do with space and its interaction with mental health in particular. So with no more ado, I'll say welcome to Chris, and thank you so much for coming, and we look forward to your talks.
Perfect. Thank you, Egenis. Thanks for the introduction, and thanks. I'll do that. I'll click it. And thanks to Hugh also for inviting me and setting this up. Thanks to Chi as well for all the instructions and clarity. So I'll start the timer. Well, as Egenis was saying, in this talk I will use the space basically to talk about 2 different projects. I will make a pause in between them. I thought it was important to explain a little bit of what I'm working at the moment, what have I been working over the last 2 years at least. Because it's also a project that I hope will branch out while I'm working at the university and at the center. And then to present a little bit on the ideas that I want to develop, particularly the project that I want to work at the center. So the first talk is called Community, Dictatorship and Utopia, the case of the protected community inside El Peral Psychiatric Asylum. And this is based on this period of time. So this was kind of in the middle of dictatorship in Chile. So this paper, or this presentation, is based on a larger project. This larger project is called Recontextualizing Psychiatric Deinstitutionalization in Chile, Local Tensions and Global Links. As you may know, the closure of psychiatric asylum is still an ongoing process in many low and middle income countries. There's been attempts at advancing this restructuring since at least the 90s. Probably in Brazil a little bit before, probably in Argentina a little bit before, because they were under the influence of Italian psychiatric reform. But in places like Chile or Peru or Bolivia, the process has been much slower. So the project in itself is an attempt to explain this lack of progress in this process, and trying to explain it outside the categories of failure that are usually used, which relate the failure of the institutionalization to lack of preparation or kind of a neoliberal push to reduce state funding, and therefore the homelessness or abandonment of patients. So I want to kind of to use sociology and to use the social sciences to enrich the contextualization of this process in Chile. This is an oral history. It's centered on the transformation of one psychiatric hospital. So it's a very focused case study. It's based on testimonies of workers mainly over 35 years. And the idea was to kind of collect these multi-voiced testimonies to try to reconstruct the process. It's important also to state that in Chile and mostly in South America, research on this process is very is driven by metrics of success, like the reduction of psychiatric beds or the investment in community mental health as different from institutionalized mental health. But there are no much research that looks at this as a political and historical and cultural process. So that was kind of the gap that I wanted to fill. In the presentation, I will talk a little bit about the hospital, its origins, the conditions in which existed over many years, and the therapeutic experiments that happened in the hospital during dictatorship. That's the focus of this presentation. So, as many other psychiatric hospitals, this started as a self-sufficient colony. So the idea was this is a picture of Santiago, and this is the Andes on the right, and the hospital is here, where for many, many years this was empty. So Santiago was just this, and this was very far away, as many other psychiatric institutions are an attempt to kind of get rid of the unruly people, and at the same time provide them with what was believed a therapeutic rural context. So this was created as an open door colony in 1928 to receive those that were considered unrecoverable from the Manicomio Nacional, the National Mental Asylum. So those patients that didn't responded to any kind of psychiatric treatment were put in this far away from the city center on a colony that was aimed at being self-sufficient, so that the patient could produce food and could work the land in order to live, and it was in itself therapeutic. That was the intention in 1928. This is a picture of it right now, and none of this existed 25 years ago. None of this existed. The city kind of sprawled into the space during the 80s and 90s mostly. The hospital is exactly where the mountains almost make impossible to build anything else. So it's a very extreme position. So almost immediately after its construction, the hospital, as in many other places, started receiving a very undifferentiated amount of people with many, many different problems, particularly psychiatric conditions, but mostly intellectual deficiencies or brain problems, or even simple physical disabilities that couldn't be taken care of in any other part of the city. This was parallel to the modernization of Santiago as a city. That means like a vision of productivity. So many other places where these people could live in the past, in the rural areas of the central Santiago, were eliminated to build houses. So suddenly you had this mass of people that kind of didn't fit into the modernization of the city, and they were then sent in trucks literally to the El Peral Psychiatric Hospital. In 1971, following the urbanization of a specific part in central Santiago, 200 patients were moved into El Peral, and then the total population was around 3,000 people. There were overcrowding at this time, no therapeutics, no rehabilitation, miserable conditions, famine, illness, and routine death of patients. This was very, as I was saying, near the Andes, so it was very cold, very windy, with a lot of snow in the winter. So it was almost sent them to die, basically. Like that was the expectation. Then we have dictatorship. I'm not going to go into the nature of dictatorship, but it was a shock, of course. But the most immediate shock within the hospital walls was a reduction of funding and personnel. So the situation, of course, worsened. Between 1976 and 78, after signing an agreement, the University of Chile started working with the hospital. We need to think that before 1973, lots of therapeutic and ideologies, I would say, started populating the country. Particularly conductivism or behavioralism was very strong, especially on the left, because it was seen as kind of a low-cost, quickly shareable sort of a way of improving citizens. But of course, the dictatorship kind of ended the community-based experimentation in psychiatry that was kind of following the line of the Italian reform, the Brazilian reform, etc. So all this process was seen as a left-wing process by dictatorship, and of course was blocked and cancelled and associated with political radicalization. But then in 1976, the University of Chile, under dictatorship, decided that there was a space to develop something medical. I would say that the aim at this point was to try to create some sort of medicine in the context of the hospital, because at that point it was only about basically stopping people from dying. That was the most that could be done within the asylum. So a group of academics developed a plan. The plan consisted in two experiences. One was the clinical psychopharmacology unit within the hospital. Something that became, the hospital became famous for the experimentation around overdoses. So at that point, it was very common to try lower doses of certain antipsychotic treatments, but the academics here decided to try with overdoses, and that kind of worked to a certain extent, but this was with no ethical oversight. So lots of suicides happened because of the overdoses and due to the experimentation. And the second initiative was the token economy program. This was a behavioralist program. This was already being tried in many parts of the world, particularly in the USA, with what was called the M&M program, which is to use M&M chocolates, yellow and red, to reward certain behaviors, and was a very structured program of rewarding that would allow psychologists mainly to train basic social behaviors, like eating with a spoon, like cleaning after going to the toilet, like sleeping in a certain way. So it required a very important amount of specialists looking at the inmates, rewarding them, and developing a system of reward that was convincing, that was serious for them. They usually exchanged those tokens for cigarettes or other foods. So this was working, and an amount of people was actually being able to be sent to the community, which was the vision of the token economy program. But in 1978, 1979, suddenly the program was stopped. For what I hear in the interviews, they say that the dictatorship kind of smelled something. Behavioralism was already demonized by dictatorship. And this was kind of a bit of a revolution inside the hospital. So it was stopped. It was seen with a certain suspicion. There was also a tension between the psychopharmacology program and the token economy program. This was a mainly biological psychiatry, and this was behavioral psychology. So there was kind of a tension between the vision of what should be done in a psychiatric asylum. And then after after these programs disappeared, there was kind of a gap and an emptiness. There was no programs. Dictatorship was at its height in terms of controlling and submitting the population to silence and to passivity. And a new authority was chosen, a new psychiatry school, Christian Wolff, chosen by the military authorities. And when this psychiatrist saw the situation, and after the demise of the token economy program, he decided that the only way to kind of recycle this initiative was to something that he called the protected community initiative. And the idea was to give some form of continuity to the token economy program, but with no expectation of externalization. So no expectations that patients will move out. Patients will be there forever. They are kind of a permanent population. So you have a permanent population living permanently on the same place, and this place kind of near to the mountains, based on many different houses. This wasn't the kind of the prototype of the massive psychiatric asylum building where everything is inside the same building. This was more like a colony. So the idea was to put little little houses on the mountain. So the vision of the psychiatrists was that this was a city. Actually, this should be treated as a city, as a normal city, as any other city in the country, where people live and dies and works and try to develop a life. The village could be organized as a typical neighborhood with a chapel. It had a chapel, it had a school, it had different departments such as the sport departments, recreation, work, economy. It had a mayor, and the mayor had a council. And the aim was for patients to have a real life within the walls of the asylum. So the school provided primary education to underage inmates. There was a small polyclinic, because if this was a city, then it needed kind of a public health approach, some form of primary health care. So it had a polyclinic. It had sport and recreation with small Olympics, weekly dances, a maintenance and facilities department charged with keeping the village clean and tidy. A department of work led by occupational therapists managed different workshops, including agricultural work, a broom factory, and a sewing workshop. And the council included a reduced number of patients, those with better conditions according to the mayor who I interviewed. The community was designed that way to foster interactions, and to use those interactions as a therapeutic mean. This is usually how community is seen within mental health policy discourse, providing new roles, and those roles weren't only for patients but also for the workers. So the idea of this leader was to involve everyone in this dynamic. So it was a therapeutic, an organizational, and a kind of human resources related solution at the time. It was the outcome at the same time, and this is important, of new fresh funds coming from inmates' pensions, because in 1986, approximately, there was a new law that forced the government to provide some sort of individualized pensions to people with disabilities. And since all the population inside the hospital counted as people with disabilities, then suddenly they had an income, and the hospital decided not to give them directly the income, but to use it in something nice for the patients, basically. And this something nice was the city. So it has decoration, alleys were given names like streets with symbols. A house was created so that patients could kind of experiment with living in a normal house, so that they could eventually move out. And I discovered this while doing interviews, so this was kind of new, and it wasn't accounted in the prior description. So I became a bit fascinated, I would say. And then the initiative ended abruptly with the end of dictatorship in 1990, when a new director arrived. So that was it. I'm going to talk a little bit about the significance. So what I'm trying to say is that in most of the descriptions of psychiatric rehabilitation and the modernization of psychiatry in Chile and South America, initiatives such as this doesn't count, because this is kind of a weird thing that a weird guy invented within the hospital before the real reform came. And the real reform is to close down the asylum. So anything you could do inside the asylum without expectations of patients moving up was just another form of control, another form of manipulation and deceive, in a way. This is what the mayor told me. He said, the only thing that makes me proud of this crazy idea is that although we were living in a dictatorship, I was the only city mayor not appointed by Pinochet. So we need to look at this in the context of dictatorship. So dictatorship meant the dissolution of the vast grassroots political organization of the country in the 1970s. The asylum in this context wasn't perceived as a threat under the authoritarian radar. In Chile, at least, dictatorship didn't use psychiatry as a means of torture, because it was much more extreme than that. So there was, for dictatorship, there was no need to kind of manipulate or control political dissent. It was much more brutal in the sense that it simply made people disappear or kill them. There was no use of psychiatry as a tool of kind of a state violence or state control. So the asylums could live in a relatively free from interruption or free form use by the military authorities. And in that sense, things could grow inside this space. They were in a way a shelter of ideas. So as I was saying, most testimonies and available accounts consider that this idea was at best an innocuous lie and at worst an exploitative scheme to steal patients' pensions and force them to work for free. It was never documented and in its large excluded from the available reconstructions of the process. It was kind of a frozen fantasy world with no expectations of mobility. So dictatorship in a way reinforced the perception that the outside world was unwelcoming, cold and brutal. So the idea of moving people out was kind of a block, not only because there were no therapeutics and no rehabilitation, but because the outside was a completely controlled, dangerous space. So the whole idea of, okay, people can live back with their house, back with their mom and dad, or with some family, or have a business, or let's help them be productive. None of that made sense to a certain extent. So what you could do was limited to the walls of the asylum. The initiative represents an exercise in what I call sociological imagination by institutional psychiatry, because this is psychiatry imagining how a city could work, how relationships could work, and to what extent the working of a city and the working of these relationships could be therapeutic, could be as similar as possible to what normal life is. And that normal life at the time didn't exist in Chile. So it was kind of a refuge of the imagination, kind of a, this is not happening in Chile, people is being prosecuted, there is no community outside, so what would a community look like? And one could trace the history of the institutionalization, the history of these attempts to reach the outside, by tracing these projections of this outside, these imagined social worlds of psychiatry. So at the end of dictatorship, the idea was abandoned, and a completely new team was put into the asylum, and a more democratic vision of psychiatric transformation emerged, which was basically closing down the asylum. But what remained, as far as I know, and this is why I'm trying to argue in a piece, is that first community became the horizon. So community is that thing that we are trying to reach. And mental health policy in Latin America and many other parts of the world move into the community mental health model. So community is the model that kind of help us to define what is a good service, what is a good interaction, what is good treatment. And my point is that in the case of Chile, the roots of this are in this initiative, the roots of this view of community. And then community as automatism. This is also something that I'm trying to develop, which is the idea that once things operate as a community, then things start happening in them without the need of a professional push or a professional oversight. It seems like community is an environment in which things can flourish automatically. And that this is also related then to neoliberalism and the attempt to replace psychiatric asylums with community, with something that would create itself based on the relationships between people. So thanks. So this is a project that I'm starting at the moment. I'm actually in the process of obtaining ethical approval for this. I have conducted some informal interviews with people back in Chile about this, and I'm at the moment of conducting a literature review on this. So I have some elements, but I wanted to present the idea. So the name of the project is this. It could change eventually. It's Healthcare as Protest, Medical and Psychological Responses to State Violence in the Context of large-scale urban revolts in Latin America. Of course, the context of this is the relationship between health and protest, which is a complex, multifaceted, multiple relationship. One could at least distinguish these three levels, and this is what I'm trying to do. So one is healthcare as a concern of protest, so access to healthcare, for example, as a cause behind the decision to organize and demonstrate, and this is kind of very similar, but access to healthcare as the goal of protest, and sometimes as the unintended goal, for example, as something that happened because of protest. And this is related to access to healthcare or to the right to health. Then you have protests that are trying to confront the actual potential harms of public or private inaction. So protests, for example, related to global warming or to particularly the extractivist industries in South America receive a lot of pressure because they contaminate rivers or they create pollution, and this pollution actually has an impact on human health. So those are another source of another way of understanding this interaction. And then a relatively new form, which is the protest as a reaction to public health measures. For example, the recent chain of reactions against the COVID-19 measures in Europe particularly, and also in other parts of the world. Then you have another way of understanding this interaction is by looking at the direct physical harm that results from protests, violent clashes with the police, non-lethal weapons, etc. You also have studies, increasingly more studies around the positive or negative mental health effects of protest, of protected urban unrest, including some research that indicates that there are some positive effects of protests in terms of human connection and certain expression of certain feelings, etc. And then there is the space that I want to explore in this project, which is protest as the scenario of healthcare. And basically this means students or professionals or voluntary groups providing first aid, providing medical and emotional care to protest participants and to victims of police violence. So this is kind of the space that I'm trying to approach in this project. We know that some particularly extensive protests, because this is not just one manifestation or a couple, sometimes it's weeks or even months. They have this ability to foster the development of a local army of voluntary organizations to support and medically assist protest participants. And this is different from the state, from what is normally available in terms of healthcare. And also it's different from international humanitarian organizations, because this is kind of a politically motivated form of healthcare. And this has been studied in Turkey, in the Gezi Park protests, in Egypt, and also in Ukraine, in the Euromaidan protests, where you had a contingent of particularly medical professionals on the streets providing care. And this is, for me, is relevant because we usually use the notion of crisis. Crisis is kind of the notion that, at least in medical literature, is used to cover a range of things, from mass displacements of people, internal wars, or natural disasters. So this is all translated as crisis in terms of what medicine can do. And I think that this is a problem, because this kind of erases the political motivation that underlies protest, and not only protest, but the political motivation of medicine itself, in a way. While sharing similarities with disaster or conflict zones, protest medicine kind of hasn't stabilized in academical or practical terms. And the invisibility of protest as a formalized setting of medical or psychological action helps to erase the damage inflicted upon protesters and relativizes the need for further reparations. So this is seen as, I mean, protest in itself is something that is difficult to anticipate. It's difficult to plan state provision or medical action. Like, I don't know, in this year we will have 15 protests, so we should allow a certain budget for protests. That doesn't happen because protests are not supposed to happen in a way. So that's why it's interesting to see what actually happens, how things are actually organized in the context of protests, in this kind of a exception. Santiago's estallido social means social outburst. This was the name that was given to a series of protests in Santiago at the end of 2019. A series of demonstrations from October 2019 to March 2020. So this ended with COVID basically, and ended because of COVID. These protests started as a response to the race in Santiago's subway fare. As many other protests, they start with something very, very minimal, very simple, that creates a lot of discontent, and somehow it became probably the largest protest in Chile since the end of dictatorship, or at least in 30 years. Sorry. It's considered the worst civil unrest in Chile since the end of dictatorship, due to the scale of damage to public infrastructure, due to the number of protesters, and due also to the measures taken by the government. The protests were responded with unprecedented violence, resulting in 3,765 wounded persons, including 2,122 receiving gunshots, 411 with ocular trauma, and 34 with permanent loss of one or both eyes. So 30 persons died. And this, the mutilation of eyes became kind of a symbol of what the government was doing at the time. And something very similar, what already happened in France after the Gilets Jaunes protest. Also, there was ocular mutilation also in Ecuador, also in Colombia. So you can see kind of a trend in non-lethal, very disabling sort of forms of police control. And the reaction of the medical community, including nursing students, psychology students, medical students, kind of was an outcome of the level of bloodshed and the level of damage on the streets. So the project is focused on the deployment of self-organized health brigades, supporting protesters and attenuating the harmful effects of police action. The aims of the projects, the general aim of the projects is based in Santiago, centered on the actions of these groups, explore how forms of medical and psychological care linking people, space, values, and forms of knowledge emerge and respond to unaccountable police brutality in the context of protracted urban revolts, and how this informal care infrastructure shaped and are shaped by the atmosphere of protest. So I'm mostly interested in this interaction and in what does medicine add to protest beyond caring for wounded bodies. What kind of a symbolical, or what kind of symbolic power does medicine add to the aims of protest itself, and at the same time how the context, the environment, or the atmosphere of protest shapes the values of medicine, shapes the things that medicine routinely holds true and affects the disposition, the action, etc. These are some specific aims. So I want to explore the contradicting values and emotions like humanitarianism, political engagement, rage, fear, how these values and emotions shape the way these brigades organize themselves, and the way people became part of them. So how individuals, in a way, decided to do this. And from what I know, the case was that most of the people was in the protest as protesters, as protest participants. And when they saw what the police was doing, they decided to kind of shift their action, but never stop being a protest participant. So not acting in the name of medicine, but doing medicine in the name of protest, basically. I want to understand the organizational or technical aspects involved in the deployment of this brigade. So for what I know, it was highly structured, using cell phones, conducting triage, deploying according to the need of the day, etc. There was a structure. Not everybody was part of the structure, but many of them were. Identifying the boundaries between brigades, protesters, and the police. These were the main groups, in a way, that were in this battlefield. and how the boundaries between them were created through, for example, symbols, as you can see in the pictures. Each brigade, each group kind of painted their own symbols. There was a strong component of creativity in here. And they needed to be identifiable, not only by protesters, but only by the police, so that they wouldn't be attacked. The cross was a way to say to the police, don't attack us. And that was kind of partly successful. Trace how the relevant professional communities, and this is kind of a bit larger aim, how the relevant professional communities like medicine, nursing, psychology, and psychiatry reacted in general to the harmful actions of the state and the work of this brigade. So I want to understand all the letters that were written, the position statements, the Twitter activity of people representing these professions. So how the professions in a way responded to this. And then finally map the position and movement of these brigades across the city during protests and understand how they experienced, navigated, and tactily used the city, because the city became a scenario of war almost. So they had to choose places where, for example, the gases weren't that strong, places that were more ventilated, places that were more protected from the police. And there was kind of a logic of using the city as a clinical space in a way, or as a space where they could have some shelter and could shelter others. So I want to understand that as well. Last slide. So in a way, this is kind of about the larger questions, which are always important. I want to kind of understand how protests and contributed how these professions contributed to protests. So at least in Egypt, research on I forgot the name of the square. There is evidence that the presence of doctors and the presence of professionals was a strong kind of gave legitimacy to what the protesters were doing, not only in terms of the feeling more brave of acting in a almost reckless way, knowing that there was a doctor that could provide help, but also the fact that doctors are very highly esteemed people in the community, and the fact that they were there meant that the whole thing made sense. The whole thing was actually for a reason. And this was also part of what I've been hearing in Chile. So this whole, in a way, the capital that medicine can place in context of political tension, I think it's important. There's also the fact that these groups had to work with no routinary clinical enclosure, so no hospital, no symbols, nothing of what actually defines lots of what medicine is all about. The expectations, the hierarchies, the specific words, the specific attire, etc. None of that was there, but they had to create some sort of clinical order to be efficient, to respond to the situation. And I want to explore that as well. And finally, probably the larger question is how certain medical cultures of resistance emerge in the face of repressive authoritarianism that we know are kind of here to stay. So that's it.
Great.